It's a pleasure to introduce our final speaker of this session and of the day, Dr. Georg Schett. Dr. Schett has been gracious enough to present lectures that bookend this outstanding day of medical education. And because you were introduced to him before the first lecture of the day, I'm not going to repeat his entire biography, but I do want to highlight some of the outstanding features of his biography. Dr. Schett is known all over the world for his work. He has published more than 760 articles in peer-reviewed journals and has been invited to more than 660 congresses and conferences. Since his appointment at FAU in 2006, he has maintained close links with an ever-growing number of national and international collaborations on joint projects, and he has been the vice president of the Kennedy Institute of Rheumatology in Oxford, UK, since April 2021. He is going to talk to us to end this day of education about psoriatic arthritis, deep dive from physiology and to pathology. Dr. Schett.
So I'm not vice president of the Kennedy Institute, but just of my universities. Just to make it clear, I also changed for Len the outfit because he's always dressed in black. So I thought that it gives me some credit. So I thank you for the invitation again. And I was given the topic to speak a little bit about from pathophysiology to pathology or clinic in psoriatic arthritis. And I want to worship our dermatology chairman. That actually the dermatologists, he always struggled to differentiate disease, right? And when you look at these two pictures, you will say, well, these are both probably psoriasis lesions. They are papillous lesions with desquamation. But actually, they are very different. And it was owed to the contribution of Ferdinand von Hebra that he realized that a similar appearance of a lesion in the same organ can have very different reasons, and that was a differentiation between psoriasis and leprosy. Leprosy is probably not that frequent anymore, but at the 19th century, this has been an important differential diagnosis of psoriasis, and he could differentiate this for the first time. What is also interesting conceptually that this reminds us to cars, right? Cars always have a similar appearance. Because they have to bring you from A to B, but they can have very different fuels. They can have very different pathophysiology. They can be petrol-driven or energy-driven or solar-driven, which is a little bit more exotic, or hydrogen-driven. So it shows that why I show you that, because I think we have developed, and Elaine said that very nicely, we have developed in targeted therapies substantially over the last decades. And we always think that basic science has driven the knowledge in clinic, but also the knowledge from clinics, from targeted therapies also stimulates differentiation of human diseases. And now we can often better differentiate diseases based on their mechanism, their fuel they use. And going back to this initial slide, both psoriasis and leprosy also affect other tissues for different reasons, of course. In leprosy, it's a neuropathy, and in psoriasis, in psoriatic arthritis. So this is an interesting concept that the same process can link different organs. It's like atherosclerosis can manifest in the brain, in the heart, or in the peripheral arteries. It's similar to inflammatory processes. And this was actually then discovered or described initially by Jean-Louis Marc Alibert, who coined the term psoriasis arthropathica, which is still very relevant, and that's why we sit here, a similar process, underlying process, linking the skin and the joints and probably other tissues, like, for instance, the cardiovascular system. Now, this is going back to the example, the coffee machine and the car look very different, but they can, indicating different organs, but they can be actually fueled by a very similar process. Now, this is relevant because we still live in a textbook kind of understanding of inflammatory diseases. This is a disease of the skin, this is a disease of the gut, this is a disease of the joints or the brain. But I think that's already partially left in oncology, and I think more and more we leave that also in inflammatory medicine, and this is just highlighted by this tree here, that of course TNF is a common trunk for many inflammatory diseases, not all of them, but then other cytokines differentiate the branches, and you can see here an interleukin-1 branch for certain forms of juvenile idiopathic arthritis or in gout, an RA branch with IL-6, a IL-23 branch with for IBD, and the combination of psoriasis and psoriatic arthritis with a combo of IL-17 and IL-23 arm. And axial spondyloarthritis differentiating actually to be IL-17 driven much more than IL-23 driven. Now, this has also consequences, this concept, because we know that, for instance, when we judge that psoriasis or psoriatic arthritis patients are not inflamed or inflamed based on the CRP, they have a big problem because psoriasis can be pretty severe, but there is no CRP. These are psoriasis patients. These are psoriatic arthritis patients without psoriasis, and these are patients with enthesitis who have a family history of psoriasis. And you can see actually only in a subset of patients with swollen, usually those with swelling of large joints like the knee, they develop a CRP, but the overwhelming part of psoriatic arthritis patients and basically none of the psoriasis patients and the enthesitis patients develops a CRP, indicating that there is much less interleukin-6 signature in the system. So interleukin-6 or CRP is a very bad parameter for activity of psoriatic disease, unless it's still not, used in the ACR criteria. And Elaine has actually very nicely pointed out that these criteria have been adopted from rheumatoid arthritis, where you have seen IL-6 is a central factor in disease pathogenesis. Now, we always think that we have a huge progress in psoriatic arthritis, but I just want to say, yes, therapeutically, yes, that's absolutely clear. But understanding of the disease has been coined in 1973 in a way usually we would write a review on psoriatic arthritis in 2023, namely that it has been, there are environmental factors as well as genetic factors responsive for the development of psoriatic arthritis, and environmental factors trigger arthritis in genetically predisposed individuals. That has been actually discovered or summarized very nicely by Mullen Wright in the so to say first modern description of psoriatic arthritis. And it's true, it still holds very much true. I want to share with you this concept in a moment. Now, what we know is that there are probably three key factors which set a state where you are more prone to develop psoriasis and psoriatic arthritis. Definitely genetics, then mechanics and metabolism. And a considerable portion of the inflammation in psoriatic disease is a so-called mechanoinflammation, which then drives skin disease, enthesitis leading to nail disease, peripheral disease, and axial disease, and occasionally also the development of uveitis, as we have seen in the case before. Now, genetics play an important role in the daily life of us as doctors, because we ask the patient with arthritis, do you have psoriasis, or does any relative have psoriasis? And that's an important step to basically diagnose or move actually the disease into the label psoriatic arthritis. And that's also very much true, supported by data from siblings having a 4 to 19-fold increased risk to develop psoriasis. What is also important that the disease is actually an MHC class 1 driven disease, which is different from the classical autoimmune diseases, which are all MHC class 2 driven. So in fact, when you screen rheumatoid and psoriatic arthritis, there are far more differences than commonalities. One of the few commonalities is that they both respond to anti-TNF agents. What is also important in genetics that there is a very strong link with the IL-23 receptor, which is also found in IBD, and it's also found in psoriasis, or psoriatic arthritis, and in ankylosing spondylitis, linking these diseases to a certain pathophysiologic pattern. Now, mechanics has been described by Koebner. Psoriatic plaques usually are developing at places where there is mechanical irritation. This is indicated here by this tattoo, and there is a very strange and sustained response, inflammatory response to mechanical irritation, which we know as Koebner phenomenon, which is probably genetically driven, and it's probably related to the fact that there is a aberrant resolution of inflammation in psoriasis patients. And there is a lot of importance for that in psoriatic arthritis, because we know that, for instance, trauma is actually an important precipitator for the transition from psoriasis to psoriatic arthritis. We know that mechanical stress at the tendons and ligaments and entheses triggers the production of prostaglandin E2, which is an important pro-inflammatory mediator, which leads to vasodilation, but also important pain mediator, as shown here. And finally, there's an intimate link between COX-2 activation and interleukin-17 production, explaining sometimes why IL-17 can be produced in the absence of interleukin-23. Now, this strong mechanical link is shown here, that enthesial anatomical sites like the Achilles tendon insertion site, the patella tendon, and the lateral humeral epicondyle are actually stress responsive tissues. And this is actually the BEAT studies we did a couple of years ago, and we let actually people play badminton and did a pre and post analysis of the Doppler signal in the ultrasound in enthesial sites, and found actually an increased inflammatory response. And this inflammatory response seems to be much more pronounced in patients with psoriasis. Now, what is the typical lesion? The typical lesion is, and that's not only a classical enthesial site, but also at the joints, because even at the finger joints, the inflammation in psoriatic arthritis is actually a periostitis. It's an extra-articular inflammation initially, which then also involves later the joint. So it's an inflammation at the insertion sites of tendon and ligaments, which is often then associated with a substantial osteitis. And osteitis is usually very painful because the bone marrow has a lot of nerve fibers. And this actually inflammation progresses and then leads to kind of a stress response, which induces new bone formation. I will show you in a moment. Now, these enthesial sites harbor cells which are interleukin-23 responsive. These green cells are gamma delta T cells, which are found at enthesial sites like here, the Achilles tendon, and they are basically stimulated to produce cytokines like TNF and interleukin-17 upon engagements of IL-23. So this is probably an intrinsic stress response element of the body to prevent us actually to overdo and to stop, because we develop pain and inflammation locally at these sites. And this level is obviously much lower in patients with a certain genetic background related to psoriasis. What happens at these sites is a structural remodeling of the enthesial sites. There are more nerves growing in that, so there is a state of hyperalgesia, and there is also a higher vascularization in this usually bradystrophic tissue, and it's most likely that this vascularization stems actually from the neighboring bone marrow, because the insertion sites of the ligament and the tendons is actually at the cortical bone, creates a very porous place. It's like the branches or the roots of a tree where the tendon is anchored, and here vessels sprout and actually then sprout into the enthesis and trigger a susceptibility to inflammation. Now, we know that when there is classical enthesitis present in a patient, that this patient suffers more. This is the famous spider diagram on the SF36 diagram. So this is actually how you feel as a healthy individual, which is dependent on the jet lag. It's smaller or bigger, but you can see that when you have psoriatic arthritis, you basically go more to the center, meaning you have a lower quality of life. And this is even worsened when you have a presence of enthesitis, which is clear because if one key joint is actually inflamed or one key enthesis is inflamed, you cannot move that well and you are physically impaired. What is also important to know that it's not like we are crazy to count joints in all the studies, and we think that the more joints are involved, the worse the situation is. This is actually not true when you look at these studies, which is I found very interesting. They compared monoarthritis, oligoarthritis, and polyarthritis, all PsA, with the reference basically superimposable, meaning that when you have monoarthritis of a large joint and you have psoriatic arthritis, your burden of disease can be substantial. And that's also not reflected in any of the clinical studies, which usually recruit only polyarthritis patients. Now, enthesitis and synovitis are fundamentally different from the basically metabolism. This is a study we did recently, which is the so-called MSOT. That's a technology where you can basically look at tissue metabolism. And what you see here in synovitis patients, there is actually a stronger oxygen consumption. There is increased oxygen in general in the tissue, which means there is higher vascularization, but there is also a very strong oxygen consumption leading to a drop in O2 levels in the joints. What you also see, there's an increased lipid content in synovitis, whereas in enthesitis, there is increased vascularization, as you see here. There's not much oxygen consumption, but there's increasing collagen, which indicates that there is a tissue response going on in enthesitis. So you can see that these two features of the disease are essentially different, and most of the knowledge in psoriatic arthritis obviously stems from enthesitis, which is also methotrexate sensitive in contrast to enthesitis. So when you look at studies on methotrexate, those with RA like PsA respond best. This is the polyarticular symmetrical phenotype, but it's not the oligoarticular and enthesial phenotype. And this is shown here. We did a couple of years a study where nobody used ustekinumab in Germany. We said, let's try ustekinumab because it's a drug you inject every 3 months. The patient comes, gets the injection, goes home, and comes again after 3 months. So very simple in the application. And compared this with the TNF inhibitor group, so these are the 3 measures of enthesitis, spark, masses, and LAI. Both drop, but there was actually a better drop even in the ustekinumab arm, suggesting that we should understand much better actually the oligoarticular enthesial-driven disease in PsA, where there are almost no studies. What does it mean clinically? Well, I think it is important to train enthesis with regular sports and exercise like muscle strengthening and stretching. And I think what is also important to use occasional non-steroidal anti-inflammatory drug at a sufficient dose for a short time to basically turn down inflammation. Now, the second key part are metabolic factors, and this is attributing to both skin and joint disease. It's pretty amazing that actually the psoriasis risk is more than doubles with a BMI over 35. And this is probably not only based on the presence of adipose tissue, but it's also linked to a deeper metabolic change because there is an increase of long-chain saturated fatty acids in psoriatic disease. And these actually long-chain saturated fatty acids, I will show you that in a second, are pro-inflammatory and induce cytokine release by macrophages. Clinically, this is extremely important because when you can convince the patient to lose weight, the likelihood that you achieve a minimal disease activity, which is a commonly accepted criterion of good response in psoriatic arthritis, is 3 times higher if it's a 5 to 10% loss of weight, and it's 6 times higher when it's a more than 10% loss of weight. So it shows very nicely that we should not only stick to increase our anti-inflammatory efforts in patients, because sometimes other efforts might be equally important, and the comprehensive therapy of psoriasis and psoriatic arthritis is extremely important. Just going back to these metabolic changes, we know that, for instance, palmitate and steroid, which are both long-chain fatty acids, have a quite strong capacity to trigger the release of TNF-alpha, interleukin-8, which is a neutrophil attractant, and interleukin-1 beta, from macrophages, thereby stimulating, providing a link between the altered metabolism and the inflammation in psoriatic disease. And a pretty interesting study also comes from Chris Richlin, which fascinated me. What he did, he compared psoriasis patients, then psoriasis patients who developed psoriatic arthritis later, and psoriatic arthritis with respect to metabolomics. And he showed that he could differentiate these three groups. What is quite interesting, that he could differentiate the group developing psoriatic arthritis from the psoriasis group. And the biggest differences were actually in eicosanoids like 12-HT, and also at certain fatty acids, which are polyunsaturated fatty acids. And also what is quite interesting, bile acids. And bile acids are considered to be very anti-inflammatory, and they could differentiate actually progressors from non-progressors, indicating that there's a very fine signature of psoriasis and psoriatic arthritis, metabolic signature, which determines actually progression to joint disease. Now, this whole metabolic link of psoriatic disease is also leading to a higher risk of cardiovascular disease. We know that the cardiovascular event risk is higher in patients with psoriasis and psoriatic arthritis. We know that actually it's happening early in disease, that there is an increased calcification burden, which is shown here in the patient. And there is when there's a good control of inflammation, by therapy, it improves the coronary plaque burden. What is quite interesting here in this PET scan, you see that psoriasis is actually a systemic disease, and that's very well known. And here you can see that the plaques are seen in the PET scan, and also the vessels are shown that there is a vascular inflammation in this disease. So what does it mean clinically? Well, I think weight loss is critical, as we said, but also lipid-lowering drugs and metformin might be very important in our comprehensive treatment. Now, cytokines play a key role, as we have heard, and there are three cytokines, IL-23, IL-17, and TNF-alpha. They have a very different function in psoriatic disease. IL-23 is an inducer cytokine, which is built, for instance, in the gut and in the skin, and is orchestrating actually the inflammatory response, and is orchestrating the shift of the disease from the gut and the skin into the joints. IL-17 is an important enhancer cytokine because IL-17 has one key function. It's a very good mobilizer of neutrophils to the skin, to the joints, much better than TNF, and therefore it enhances the inflammation. And TNF is an effector cytokine which is produced by the bone marrow-derived macrophages locally in the tissue, and then triggers inflammation. We are very good in inhibiting inflammation by our current drugs, because when you look at this, you can see that after 1 week after interleukin-17 inhibition, there is already a decrease in the synovial hyperplasia, and after 2 weeks, there is a decrease in the Bauer Doppler signal. So these drugs do not only make the patient feel better, they really work also on the joints and decrease inflammation. And this is shown here, for instance, very impressively. In this case, it's a JAK inhibitor. You can see here that's clearly psoriatic arthritis. Here you see a dactylitis. This is a cinematic rendering of a PET-CT scan. And you can see here very nicely the synovitis. You can see enthesial lesions and dactylitic lesion. And after the treatment, you can see that these lesions regress, and the volume of this lesion is really decreasing. So what we can do, we cannot make the patient completely happy with our drugs, but we can actually target very well the inflammatory lesions. Now, some patients, and this is, I think, still a minority, because I think the treatment resistance has multiple reasons. It can be anxiety, depression, it can be actually existing damage, but occasionally it can be also a resistant disease. And these are three examples of a treatment-resistant patient, patient 1, 2, 3. These arrows actually indicate skin, joint, and enthesial disease. When they are maximal, is the original baseline situation. And then you can see that these actually circles get smaller with monotherapy of TNF, monotherapy of IL-17, and monotherapy of IL-23 inhibitors. You can easily see, for instance, that the 23 inhibitor and also the IL-17 inhibitors are pretty good in skin responses, also here. But you can see that there's still a substantial residual disease activity. And then a sequential treatment, where there was a sequential treatment of IL-17 inhibitor followed by 23 and then 17, actually brought these patients in remission. So we have to also think how we can actually define new conceptual treatments in psoriatic arthritis apart from classical monotherapy. Now, what we also know is that when we treat early, and that's still a big problem, because on the average, patient have to wait 2 years till they get an adequate therapy with psoriatic arthritis. This is a situation where we have psoriasis patients, and they have joint pain. And in the MRI, you can see discrete enthesial lesions here in the wrist and in the MCP joint, and you can see you clear them with IL-17 inhibition, and you also improve massively the pain. So each line is a patient, and the patient global, the patient pain, and the PsA, which is an impact of disease score. So you can see that this initial pain and this discrete inflammation is really dependent on the disease. It's not just a serendipitous finding, which is not related to disease. It's really disease-driven, and you can inhibit it with a powerful anti-inflammatory drug. And this is also shown by the Leeds group, for instance, with ustekinumab, that patients with psoriasis having enthesial lesions in the ultrasound, these enthesial lesions go down over time with treatment, whereas the chronic damage, of course, is the same. So this indicates very importantly that early treatment is crucial. Now, this is early treatment in psoriasis patient, and there is, I think, now a shift in psoriasis also to use more systemic therapies rather than local treatments, is potentially also inhibiting the development of psoriatic arthritis, although the data are still not sufficient to claim that. But this is, for instance, an Italian studies where they compared psoriasis patient receiving phototherapy and psoriasis patient receiving biological drugs, and there was a faster progression or a more frequent progression to psoriatic arthritis in patients receiving only the phototherapy, indicating that early intervention might actually be very feasible in joint clinics between dermatologists and rheumatologists. Now, at the end of or the last 5 minutes of my presentation, I also want to address this part a little bit. I want to specifically look at structural damage here in psoriatic arthritis, which still happens, but there are also other consequences of the disease which are important to consider when we manage these patients. So what we know is that early treatment is important to prevent damage. This has been very impressively shown by the Canadian study, showing that if you have a delay of only 6 months of treatment, that your likelihood to develop erosive disease is 4 times higher, and your likelihood to have functional impairment is 2 times higher when treatment is not initiated within the first 6 months. So why is that? Well, one similarities between rheumatoid arthritis and psoriatic arthritis is the fact that in the synovium, if you have synovial disease, you get erosions. The erosion is actually a manifestation of synovitis, and that's similar between rheumatoid and psoriatic. Here is the bone, here is the synovium, here these brown cells are osteoclasts. They basically like caterpillars and eating the bone away, and that's a common feature of both of these inflammatory diseases. And we know also that usually we are quite good with, this is the first TNF blocker study with infliximab, and you can see here that the yellow line is infliximab, that many more patients are at this 0 line, meaning there's no structural progression as compared to placebo, and the same we know from other drugs like interleukin 17 and 23 inhibitors. What is interesting in psoriatic arthritis is that there is a strong mesenchymal response, and that's actually kind of overshooting repair mechanism which happens in this disease. And that's why when we actually investigate clinically patients with psoriatic arthritis, they often have similarities with osteoarthritis. We find bony swelling because after the inflammation, there is a bony overgrowth. And this is very much related to the influence of IL-17, prostaglandin E2, which is an important factor inducing osteoblast differentiation from fibroblasts. You can see that very nice. In the morning, I have shown you a FAP PET. This also works in psoriatic arthritis. Here you can see actually mesenchymal activation in the knee joint. You can see it in the frozen shoulder of a patient with psoriatic arthritis. You can see it in dactylitis here, and this is in the Achilles tendon. And this shows very impressively that the inflammatory burden of psoriatic arthritis leads to a tissue response. This is not inflammation depicted here. This is purely tissue response because this scan does not detect inflammation. Of course, there is inflammation as well there, but you wouldn't detect it with this scan. Now, this is also seen, you can do that, you don't need PET sometimes for this, but you can see that also in the conventional X-ray. And just want to highlight you, this is not rheumatoid, it's a totally different disease. It's a periostitis. You see that here very nicely, where you have the insertion of the ligaments, you get actually periostitis. You see this fluffy appearance of the periarticular tissue, which has been described ages ago. But that's actually what we see in the disease. And we call it sometimes the so-called deep Koebner phenomenon. You can see that very nicely in psoriasis patients. It's very discrete here at the same place you saw it in the X-ray. It's also here to be seen here. In the cross-section, you see it much better. This is the so-called deep Koebner phenomenon. And when you find that, the risk to develop psoriatic arthritis is very high. You can see here the PsA-free survival. When you don't have deep Koebner lesions, they are pretty stable, don't get psoriatic arthritis, but if you have these enthesial lesions at the beginning, you have a very high risk to develop psoriatic arthritis within a quite short time frame, which more or less 9 months. So this is actually highlighting it very nicely. In established PsA, then function of patients is often determined by these massive enthesial lesions. You see erosive lesions, but you see actually strong enthesial lesions. Of course, they impact the function of the joint. They impact the function of the joint like a secondary osteoarthritis. And those of you who have experiencing hand OA patients, PIP joint involvement can be very severe and impact the function of the patient. So this is my last slide with respect to structural changes. So psoriatic arthritis has this part of structural change in common with rheumatoid arthritis. It's the periarticular bone erosion, which is driven by synovitis. It's driven by inflammatory cytokines like TNF, IL-17 particularly, leading to osteoclast differentiation. And then you get osteitis in addition. Osteitis is a non-specific feature. It can also happen with enthesitis. This is a periarticular lesion, which I have shown you. It's dependent on the differentiation of periosteal cells into osteoblasts and the formation of bony spurs. Both of these lesions impair the quality of life of patients, and they are a matter of time. The earlier you treat, the better you can prevent them. Thank you for your attention.